Okay, I think we'll kick off now. So thank you so much for joining us this evening for tonight's RTUK Talks on enhancing patient experience when it comes to the late effects of radiotherapy, sponsored by AstraZeneca. So really warm welcome to everyone. Although this is a series built for the workforce, we very much welcome anyone who has had cancer or who's going through treatment or diagnosis who has joined us tonight. Last year's talks about new development and innovations were immensely popular and are available to view on our website, as are the 3 talks from earlier in this year on the theme of enhancing patient experience. So I'm Sarah. I'm the Director of Radiotherapy UK, and Radiotherapy UK is the only charity in the country advocating specifically for radiotherapy as a life-saving, cost-effective curative treatment. The patients that receive radiotherapy and the workforce that delivers it. With your support and through our award-winning Catch Up with Cancer campaign, we are here to create change at the highest level. And I have some important updates for you after tonight's presentation. If you do find tonight's webinar and our wider work valuable, please do consider supporting our upcoming festive fundraiser. So I'm joined here tonight by Lindsay and Alison from our team, who are going to help run the session. Lindsay worked as a therapeutic radiographer for many years and will be helping out with the questions section later this evening. And Alison is our comms and engagement lead, and she'll be looking after the chat. Tonight's guest speakers have some really fascinating insights to share when it comes to late effects. In every focus group that we have run for patients, this is a really hot topic, with many feeling that they were told about their cancer and their treatment, but not really about life after cancer treatment. So please do use the chat function to introduce yourself. And for any comments or questions, this is such a good opportunity to engage with each other and also with our speakers. And we will have a question and answer section after Samantha and Karen have presented. So without further ado, I am very pleased to welcome 2 powerful and knowledgeable voices on the subject of late effects. Karen Liesching-Schroder, who lives with late effects caused by treatment for tongue cancer several years ago, and Samantha Bostock, Macmillan Radiotherapy late effects lead radiographer. So I'm going to now hand over to Karen.
Hi everyone. First of all, a big thank you to Sarah, Alison and Lindsay for inviting me to talk tonight. And also big thanks to Sam for all the work that she does. So I'm Karen, and I was diagnosed with tongue cancer at the age of 43 in 2016. Now my dentist never did a mouth cancer screening on me, so I never knew that a stubborn ulcer on the side of my tongue would actually turn into cancer. So when I actually got my diagnosis, my world fell apart. Mainly because I never smoked. I didn't drink much alcohol. I was what I classed as a healthy person because I was a runner. And I was careful about what I put into my body. So it completely shocked me and my family. There isn't much time to prepare for what's about to happen and the life-changing surgery that you have. Literally a month after my diagnosis, I was having surgery to remove the side of my tongue and a neck dissection, and had a little bit of time to recover from that, although your appearance is very different and your speech is very different, eating is very different, and it's a very difficult transition. And then I was expected to have radiotherapy, which I wasn't prepared for. I was given a booklet and asked to sign a consent form, which I did because I didn't really have much choice. I had to have the curative treatment. I was told briefly about side effects that I would encounter while having the treatment. And those were what they classed as acute side effects. So I had obviously 30 sessions of radiotherapy. On the third session, I was already experiencing burning in my mouth, which I wasn't expecting, which obviously escalated as the treatment went on. I also had oral thrush, and the best way to describe oral thrush is basically you're chewing on nails. That's actually how it feels, and it paralyzes your mouth. I also had difficulty in opening my mouth enough to put a mouthpiece in. I had to have a mouthpiece before my mask, which was very uncomfortable. I also suffered with a very dry mouth because radiotherapy affected that, and a thick mucus, which I used to refer to as gunk. It's a thick brown substance. I used to wake up every morning choking on it and making me very sick and very unpleasant. And throughout radiotherapy, I would have a toilet roll in one hand and a carrier bag in the other. I couldn't spit the mucus out, so I had to wipe it away from my mouth and dispose of the tissues into a carrier bag. It wasn't glamorous, and I even used to take this out when I was running for a bit of sanity. And obviously my speech was affected. Now, my speech was affected after surgery, and then it was 100 times worse during radiotherapy. I was never offered any speech therapy, not once. I did have a peg, which helped with nutrition, and it also helped with when my mouth was burning so much from the treatment, and I couldn't cope with eating. I got my nutrition through my peg. I got through the 30 sessions, and I returned to work, and I thought, I can do this. However, I had to prove myself. I worked full-time in a nursery within a school with 3 and 4-year-olds talking all day long, which was really, really hard. I pushed myself too hard, and I got very run down, and I knew I had oral thrush, but the professionals wouldn't listen to me, and it led to me having more of my tongue removed from underneath, which led to swallow issues and another 4 months off of work, which then led to me nearly losing my job. For 5 years, I was being seen every 4 to 5 months because nothing in this tongue cancer pathway was simple. I think because of the area it's affecting, it affects everything. And it's very easy to become run down and poorly. So I reached 5 years, which is a magical milestone. And yes, I was cancer free, but then loads of other things started happening, and that freaked me out. I didn't know that these were called rate effects because nobody ever told me. So my dry mouth started to get worse. I was having issues with my jaw locking, especially at the dentist. It was locked, and he'd have to help unlock it. I was also having issues with a clicky jaw, and my consultant noticed that every time I had an appointment. The whole weather had started to affect me. It hadn't affected me before, but the whole weather, temperature, would burn my mouth, my tongue, and my throat. I later found out this was called burning mouth syndrome, and this was likened to the burning sensation I used to get in the radiotherapy. And whereas when I was having radiotherapy, I was on morphine to help with all this, I wasn't at this time. Then I started getting nerve pain where my tongue had been removed, and this was electric shocks in varying degrees. But this pain was very debilitating and invisible. Nobody understood about it. I also started having trouble swallowing. It was getting worse. I was then diagnosed with dysplasia in my teeth from the side of the cancer, and this was caused by radiotherapy. I was getting discomfort in my throat, so I felt as though I had a lump in there constantly. I was having more and more issues with my speech. People weren't understanding me. I was having to constantly repeat myself, and the fatigue from that was so hard. Radiotherapy took away all my sensation in my mouth. I had no idea what my tongue does. I don't have a full tongue. I can't poke it out. I have limited movement. I have no idea what it does. If you say, put your tongue to the roof of your mouth, I don't know if I'm doing that. I don't think I can. However, when I have pain in my mouth, it is excruciating. So I go from having no sensation to severe pain. I also have an excessive tightness in my neck due to my neck dissection. Recurring oral thrush. I cannot tell you how much oral thrush I've had in the past 8.5 years. Intimacy issues. This is quite a big one because I can no longer kiss my husband, and it causes lots of issues within the bedroom. He is incredibly patient, incredibly loving. We have to adapt. It's not perfect. I can't talk dirty because that's a mood killer, because I hold the words out. I'm not understood, so I scrap all that now. But it is a big part of our intimacy with him, and something we really, really miss. It's been a really emotional time with that. And I lost confidence in the bedroom. I lost confidence with everything. This sort of cancer affects your everyday life. When people don't understand you, when it's impacted so much. And when you haven't got that confidence, yes, I'm confident to come on here and talk. Matt says I'm passionate about this, but I have very, very little self-confidence, which then leads to the psychological problems and having depression and high anxiety. The last couple of years have been really, really tough. I've had to overcome a lot of obstacles, and that's been really, really hard to do. So obviously, I went to my head and neck cancer department. I said, help, I'm struggling big time. I wasn't expecting all this. And I was then told, it's not cancer, and we only treat cancer here. Yeah, I was like, wow, I understand that, but what help is there? So I was then referred to the chronic pain department, but then I was being bounced around different departments. The chronic pain department, the appointments were by phone only. The speech impaired people, it doesn't work. On the first appointment, my husband was available, and he ended up having to educate the person we were talking to, the professor we were talking to, because they had no idea about mouth cancer. And it was brilliant that Ian could do that for me. But then from there, all my appointments were by myself during work hours. I couldn't spell things over the phone. I was not understood. I came away from each phone call in tears and totally frustrated. I was then referred to rheumatology. I don't know why. They didn't know why. They were baffled by me turning up to an appointment. They did a thorough workup and sorted out blood tests. Everything came back fine. I was then referred to ENT. Met a most unpleasant consultant who looked at me and didn't approve of my scar, and didn't like it, said he could have done a better job, made me feel really, really rubbish. Sent me packing. Came away from there feeling very deflated. Went back to my GP, referred to my GPs. I've had GPs that have refused to treat me. You say that you've had tongue cancer, and they say we don't want to get involved. They go back to hospital. Hospital, like the head and neck cancer department, don't know enough about their effects. And they're like, who's going to help me? So I've met so many professionals who have refused to treat me because of my type of cancer, have been rude, and have stereotyped me for smoking and drinking. I've had to educate quite a few. Now I had to leave my job in January this year due to a lot of misunderstanding, lack of understanding, lack of compassion. In my last year at work, I suffered depression and became very isolated.
Karen, you've gone on mute there.
I've just unmuted her. Oh no. Karen, you're on mute.
So I don't know what's happened there. Can you hear me now?
It's okay.
Yeah.
It was just the last minute or so. So
Okay,
you were just talking
thank
about, you're
you.
mentioning about having to leave work.
Okay, thank you. So I had to leave work because my mental health was suffering from a lack of compassion, and I couldn't do my job to my full ability, and I was being penalised a lot for it. 50% of patients with head and neck cancer are unable to return to their jobs or hold them down for any real length of time. And then I thought, I'll try and get another job. I couldn't get another job. I couldn't get a job anywhere. So I thought, great, I'm unemployable. So then I looked into claiming disability benefits. That took a while to organise, but I had eventually a fantastic Macmillan caseworker who took my hand, and we trained to do things with respect to we didn't have phone calls. She understood my issues. So we had meetings like on a platform like this. If it came to having to do calls with the disability people, the benefits, she organised conference calls and did the talking for me. It was amazing, and I finally got there, but that was a whole roller coaster of depression right there. So obviously now, for the past couple of years, I have been supporting patients and their families, just like me and my family, through the Mouth Cancer Foundation, mainly through two types of support. We offer a 2-hour weekly Zoom every Monday night, which I host with Jocelyn Harding, who is a dental hygienist and the president-elect of the Mouth Cancer Foundation. And it's a safe space for patients and family members. We laugh, we cry, we talk about all sorts of issues. And I try and make sure that each person in the group gets time to talk about what is going on with them. It's really important because some people have no support. So it's really important they have that time. I also run the Mouth Cancer Foundation support group. And that's a private group on Facebook. And we have professionals, and we have, I think, 817 members at the moment globally. And I make a point of each time a new person posts or anybody posts within the group, I personally will make sure that I answer and support as much as I can, so that each person within the group feels supported at all times. Also, if patients aren't able to access those type of support, the Mouth Cancer Foundation will send people to me to either phone, even though I hate phone calls, but because it's a patient, I will make that phone call to connect with them, and also by emailing, because some patients can only do it by email. It's really important that patients aren't alone. And then supporting these patients brought home even more the essential and desperate need for late effects clinics for head and neck cancer patients. Patients have told me things that have been said to them by professionals. I'm not here to make you look pretty. I've saved your life, what more do you want? It's not cancer, we only treat cancer here. I'm not touching you, you go back to your team at the hospital. I don't like your neck scar, I would have done it differently and better. These are controlled drugs, are you addicted? That's not my job. Now the last one, that's not my job, has been related to head issues. We're getting more and more patients coming to us that have infected pegs and not getting dealt with. One patient had to wait over a year to have his infected peg removed after nobody took responsibility for it. And it got to the point he was at very serious risk of infection. and I had to step in on his behalf to email various contacts before it was removed. I decided I wanted to do something to address the issue of late effects at my local hospital, and I reached out to an amazing professional, Nikki Wild, the head of radiotherapy physics, and we started up a conversation about this. And we asked a fellow patient suffering with late effects also, who works in the NHS, if she wanted to get involved, and she did. It is a slow process, and as always, funding is an issue, but we are still working on this. We need specialists involved with looking after us. So what has helped? Support groups and professionals who actually listen. Being proactive in trying to set up a rate effects clinic at my local hospital. Where I am now and the work that I am doing, speaking out publicly on behalf of our patients, raising awareness of these issues, public speaking at any events I'm invited to, and the invites keep coming through. Patients need all professionals to listen and be kind and mindful at all times. These patients' lives have been changed forever, emotionally and physically. Yes, I am a tongue cancer patient survivor, but I am a late effects patient. And like many of us, struggling to get by daily. There are over 60 late effects associated with head and neck cancer, and that is a lot. I am now in touch and connected with some amazing professionals and charities, including Mouth Cancer Foundation, Radiotherapy UK, Oracle Voices Head and Neck Cancer as an Oracle Voice, and we're all striving forward to make a difference and changes for patients. These professionals are within dentistry, head and neck cancer departments, radiotherapy, and rate effects. And I'm gradually working on getting GPs and primary care involved too. We have quite a few professionals active within our private Facebook group, and we are open to more, so if you wish to join us, I will let you in happily. We need the plan moving forward to be diagnosis, surgery, treatment, and late effects. You can't keep treating cancers without supporting the late effect patients are left with. It isn't fair and it isn't right. We deserve quality of life. I hear from patients with other cancers saying the same things, so I know it's not just head and neck cancer. However, head and neck cancer comes way down the list in everything. I've noticed at events I've been invited to that the interest is minimal in our cancer. Head and neck cancer, the diagnosis in this area affects eating, drinking, swallowing, breathing, talking, and intimacy, and none of these are properly addressed and looked after once cancer has been treated. Some patients require communication tools, such as speech and voice apps, but hospital departments won't get on board with helping their patients access this, which is a real shame. It shouldn't be down to patients discovering things solely through support groups. I'm going to leave you with this. Depression rates for head and neck cancer patients are double that of any other cancer, and the suicide rate is growing. Our scars are so visible. Some patients are left disfigured and with altered speech, all things that we've all taken for granted. Thank you all for listening to me. Sorry if I went on a bit too long.
You didn't at all, Karen. Thank you so much for sharing that. I'm so sorry that you have had to go through that experience as well. And thank you so much for being such a fantastic patient advocate, both for other people and for, as seen, advocating to ensure that head and neck patients and the late effects and the experiences can be better for patients coming after you and for you still now. So thank you so much. I think we will pass on to Samantha. I'll just bring up your slide for you here. And remember, if you can put questions in the chat, there will be questions at the end for both Karen and Samantha.
Thank you.
I think before I start, I just want to thank Karen immensely for that, because as a therapeutic radiographer, that's incredibly moving, and really brings home to us, I think, as professionals, the impact of what it is we do. And yeah, thank you. I mean, it was very, very moving, and I thank you for your honesty. So I've been asked to talk a little bit about radiotherapy late effects and how we can enhance the patient experience. So just to start with, I want to give a brief overview of the service that I work within. And I'm based at Gloucestershire Oncology Centre, and as part of our regional Southwest radiotherapy late effects services. And we are 7 out of 8 radiotherapy departments in the Southwest, and we're a Macmillan funded project working together to try to provide equitable and peer-reviewed late effects service to patients across our region. We were having a conversation before we came on air about funding, and Karen also just commented on funding issues. So hopefully will be commissioned. We won't know until January next year, and I know it's a cause of concern across the whole country as to how we set up and establish these services. So the most commonly seen late effects patients, I think, within my service come into 3 sort of broad categories, really: pelvis patients, head and neck patients, and breast patients generally. So amongst our pelvis patients, I'm referred people who've had prostate cancer radiotherapy for gynae cancers and anal cancers. And they have a wide range of late effects, but I think what's interesting is that more often than not, people are referred in with a late effect. And it's not until you meet the person in front of you and have the opportunity to really talk and ask what matters to them that you realise it's not just bowel symptoms or bladder symptoms, but actually it's a lot more than that. And it can be sexual function and intimacy, it can be pain, there can also be skin changes and skin problems, either related to the radiotherapy, and some of our gynae patients and some of our patients who've had anal cancer radiotherapy have telangiectasia or fibrosis or unhealing skin. But also it can be because of bladder and bowel leakage, incontinence, and that can have a big impact on people's day-to-day lives. Also, fibrosis and stenosis can be quite a problem, and sometimes people haven't mentioned this before. They've mentioned maybe that they've got bowel problems or that their bladder isn't as good as it was before, but they often haven't talked about any of the other concerns that they have. So Karen, I don't think I can add anything much to what our head and neck patients experience, but certainly swallowing is a big issue, as well as the secretions that you know we know our patients experience these things whilst they're on treatment, and talk about how they settle down, but actually it's a really significant late effect that causes a lot of problems for people. Ongoing pain and skin changes too. So a lot of the head and neck patients that I see again have been referred due to swallow or secretions or other kind of issues like that, but actually they have really, really significant skin changes in that they have tissue fibrosis, and again telangiectasia with sort of broken blood vessels, but that can impact quite significantly on movement. So whereas when you touch your skin it's quite movable, actually with a lot of our head and neck patients the skin no longer moves, it's stuck, it's quite solid, and there can be ulcerated areas and unhealing areas as well, and this is often really painful, really uncomfortable, can heal and then break down again. Osteoradionecrosis can be a big concern for patients as well. And Karen mentioned the limited jaw opening and the pain and the stiffness. And with our breast patients, quite often what we're finding is they're actually referred through with pain, and I'm not sure that we really maybe acknowledge this with patients while they're going through treatment. A lot of our breast cancer patients are experiencing pain in the months or years following their radiotherapy, and swelling of the breast, not necessarily lymphedema of the arm. And again, tissue fibrosis and skin changes can be really significant and quite debilitating for people. So I didn't want to talk to everyone today about how we manage all of these side effects. We'd be here for weeks on end. They're sort of topics individually on their own, but I think what I wanted to do was for us to think about the impact that all of these different things will have on patients, the ability that it has on what we would consider your normal day-to-day functions and activities, certainly on psychological well-being, as well as intimacy. So I was very grateful to Karen for raising the topic of intimacy issues, having had a diagnosis of head and neck cancer and treatment, because I know when I was a treatment radiographer and a review radiographer, I'm not entirely sure this is something that is really discussed with a lot of our patient groups, and thinking about the impact that not being able to kiss has on a relationship, the mucus, the dryness. Lots of sexual activities involve your mouth, and actually that can have a big impact on somebody and how they view themselves, on their relationships, and the same with our other patients as well. So I think we're probably better at talking to maybe our gynae patients about sexual function, but I think we talk about it in a very sort of maybe functional way rather than an emotional way. All of these things can have an impact on somebody's caring responsibilities. So whether that's caring for a partner or a parent or a child, certainly if you've had pelvic radiotherapy and you can't get off the toilet in the morning because you've got loose urgent bowel movements 7 times before you have had your first cup of tea, taking your kids to school is a real issue. Work, Karen's had to leave work, and she's not alone in that. People find that they can't hold down the job that they used to do before, and that might be to do with toileting issues, it might be to do with pain, lots of things, and I think it's worth remembering that has a real big impact on your view of yourself and how you fit within your role and your family and all your relationships. And also a lot of the people who come into my service have got coexisting conditions. People might be diabetic. So if we're talking to somebody who's had pelvic radiotherapy and they might have pelvic radiation disease, and we're thinking, okay, so we'll address dietary issues. Well, actually, they're a diabetic, so that's got lots of issues, and actually we're not experts in diabetes. That's not something that we know about. So there's huge amounts of other things to consider. I found it really, really interesting, Karen, saying that your oncology team have said, well, you haven't got cancer now, so we don't deal with this. And actually you're not alone in that, and I hear that, sadly I hear that an awful lot. Follow-up processes are all about assessing your tumour response and excluding recurrence, and it's all about your scan results or your PSA results, and often if you get to see somebody face to face for a follow-up, actually there's often there's an agenda. Certainly I think it's about, aren't you doing well, your cancer's gone, and there's an expectation, I think, that that's that. And a lot of our oncologists actually, you know, may only have 7 or 10 minutes to have a conversation with a patient and don't really, you know, don't really have the time and the space to have those conversations. But actually, it's really important, because a lot of people have explained to me that they feel really guilty, and they feel guilty about saying to their cancer professional, actually, I might be cancer free, and that is really good news, but I'm really struggling, and I've got these awful problems, because there's an expectation that you should be back to normal, whatever that normal might be. There's often a feeling that because you've signed a consent form and you've agreed to this, that actually it's okay that you're experiencing what you're going through. And also, sometimes radiotherapy-led effects aren't actually recognised as such by professionals such as GPs, and patients have certainly come through our hospital trust, and almost got to the point of having a colostomy because nobody recognised actually they were having diarrhea due to radiotherapy. So you know, these things happen, and there's a real need to educate primary care professionals about radiotherapy itself and radiotherapy-led effects, because a lot of people are bouncing back and forth to their GP. I think it's really important, and it's really difficult to know when we talk about late effects with our patients, and should we, as on-treatment radiographers, be having those conversations? But if we don't have those conversations, then who does? Because yes, our patients are signing a consent form, but at the time that they're doing that, they're in a position where you've been diagnosed with cancer and you need to have your radiotherapy in order to treat that. So I think you know, there's a conversation to be had about when we have these conversations with our patients. Do we do that at the beginning? Do we kind of talk about it during radiotherapy, at the end of radiotherapy? And actually, I'm not entirely sure there's a set point in time where we should do that. I think it's important to raise the conversation and ask patients what they'd like to know and when they'd like to know it. It's really important that we're raising awareness, because people need to know so that they can flag these things and seek help and advice earlier, because living with radiotherapy-led effects, I think, can be very lonely and very, very isolating. I think we need to take every opportunity that we can to give information at a point and at a pace where patients are ready for it. And even, you know, with our pelvis patients, simple things like, you know, we're getting our patients to do their pelvic floor exercises, but saying actually this is a forever thing, and you know, you may always need to do these, because some of the things that might crop up in the years following your radiotherapy, pelvic floor exercises can be really helpful with that, as an example. Perhaps identifying which of our patients are high risk, who do we know are going to struggle with late effects potentially, like our head and neck patients, maybe some of our gynae patients and our anal canal patients, and we have a professional responsibility, I think, to have those conversations and make people aware that they may happen. They may happen months or years later, or actually our acute side effects may never settle down and never go away. And I think we need to be really careful over our choice of words and how we're describing acute and late side effects to our patients, that you know, the stereotypical kind of things peaking 2 weeks later and then at 6 weeks you'll be back to normal. You know, we know that that's not actually the case. Everybody's different, and it's having an honest conversation. And I think that's what is really important perhaps to take away from today, is that it is okay to talk to patients about late effects while they're on treatment. It's important to be honest with people and empower people to know that if they are struggling in the weeks and months and years following their treatment, actually it's okay, you know, to raise these issues with the healthcare professionals and have information at hand to give to patients. So Macmillan, Prostate Cancer UK, Breast Cancer Now have all got booklets and information available about late effects to patients, and so you can have those. If you're lucky enough to have a late effects service, then you know you already have information at hand. And I think it's more about preparing patients rather than frightening them or scaring them about late effects, because my job is living and breathing radiotherapy late effects. But of course, there are huge amounts of patients who have their radiotherapy and don't experience debilitating late effects. So it's not about saying to everybody at the end of their treatment, this is what you'll experience. It's about preparing people and being honest and giving them information that they're entitled to have, so that they can you know, make informed decisions and informed choices and know what to look out for. Maybe I think, sorry, I've just lost my train of thought, Lindsay, because I think you popped a question up that I wanted to talk about. Sorry, I think you're on mute.
Yeah, there are a few questions coming in, but I can ask them at the end unless there's something you specifically
No, that
want
was
to talk
okay.
about.
I just noticed that you asked about what mindset I bring up, was it what mindset I take to my appointment? So
Yeah.
we within our regional services, we thought long and hard about how we wanted to run an appointment and run a service. So we send out a huge amount of outcome measures and questionnaires to patients before we get the patient in to see them. So we're sort of fully armed with all of that kind of information, and we look at their radiotherapy treatment imaging and plans and things, so that, you know, we're fully prepared to make the most of our time with our patients. But we also ask them what matters to you, and like I said at the beginning, patients are often referred in with a tick next to bowel or a tick next to bladder or dry mouth or something like that. So we always start off by saying to the patient, you know, there isn't a magic wand. We might not be able to get rid of your side effects. Often late effects are progressive. But what we're aiming to do is to hopefully implement strategies, actions, maybe prescribing, that kind of thing, to reduce the impact that these late effects have on their quality of life. And actually, what matters to you? What is it that's important to you? Or what do you want the outcome to be today? So often that's not exactly what's written on the referral form. And it may be that they want to be able to carry out a particular activity, or they might have been referred for bowel problems, and actually their problem is that, you know, they want to be able to have sex with their partner, or you know, that kind of thing. So we sort of start off by listening, and it's really important because a lot of these patients feel they haven't been heard. So I always I go in prepared. I go in with a bit of my own agenda, which I know is not what we're supposed to do, but I like to go in with lots of things at my fingertips, so that if it's appropriate to give information, leaflets or booklets, or talk patients through particular techniques that might help them, then I'm ready to do that. But also listening and acknowledging that, you know, they're not alone, they're not going mad, they're not imagining things, their symptoms are not due to their cancer coming back because it's been investigated prior to me seeing them. And that's really, really important, because virtually everybody I see in late effects is really frightened, really frightened, because they don't know what's going on. No one else seems to know what's going on. Is it the cancer coming back? You know, what's happening? Is it my fault? Is it something that I didn't do right while I was having my treatment? Did I not fill my bladder properly? All of those things. So we listen and we hear what the patient feels, and hopefully we acknowledge that, and together we come up with a joint action plan, which I'm going to go away and do some things, they're going to go away and try some things, and it's an agreement that's what will happen. There may be other referrals that come out of our conversation, and then I write very long letters to patients, so they don't have to worry about making notes during our appointment. So they've got that record, and I copy that to the referrer and any other health professional that the patient and I feel it's appropriate to do so with. And then I'll call the patient to check in on them a few weeks later, and that's really a bit of a sort of a nagging session. So, you know, when we met, we talked about how important it is to start doing pelvic floor exercises. Are you doing them? And then go from there, and maybe to see if there are any more questions that the patient might have had from our appointment together. And then depending on where we are, what's happening, we'll arrange a follow-up appointment for a while later, which may be a number of months, to check in. And in an ideal world, what will happen at that point is that the patient's late effects will be better managed. They'll not be having such an impact on their quality of life. Invariably, what happens is often things are improving a bit, but something else might have cropped up, or what we've tried hasn't been as effective as we hoped. So there might be further actions to take, further things we can try. And so we'll continue on that kind of pathway until the patient feels that that they're at a point where they feel they're happy to be discharged. And we're always discharging our patients with open access, so they can come back in or contact us without needing to be referred back in again.
That's brilliant, Samantha. Thank you so much. I think we'll move on to questions now, if that's okay, if you're happy to. That's absolutely fascinating. I know we've got some great questions, so I am going to hand over to Lindsay, who is going to the questions.
Hi, yes. So I'm going to remove the spotlight so everyone can see everyone. Karen, what difference do you think the knowledge of late effects, what difference would it made to you if you had known about them sort of during or treatment, or like as soon as you'd finished type thing?
I would have known what to expect further down the line. There wouldn't be that instant fear that it's I've got cancer again, an understanding of what could be happening, and some knowledge of knowing who I can go to get that support. The fact that you're not told, you're kind of told that for 18 months after, once you've reached 18 months, you'll be fine. If you haven't had anything happen, don't worry, that'll be fine. That'll be it from now on. So then to start experiencing things, it's just, knowledge is key. We all need to know these things. I know there's not a great time for finding out and having that conversation, but surely there's a responsibility to inform the patients what could be happening and what they could expect. I think more patients would rather know than not, because it's very scary. Yes, we live with a constant fear of recurrence or another cancer in that area, but we also, it's such a lonely experience for all of our patients everywhere. Nobody asks for cancer, but what we do ask for is quality of life. And I personally would have liked to have known what to expect, and also to expect that I could be helped.
Thanks, Karen. Sam, in your experience, have you got like an example of when sort of all the relevant clinicians and carers and everyone has linked in to provide sort of good long-term care, and what that looks like? Do you have that now in your service, now you've set it up?
I think That's a good question. What does it look like? I think it looks different for for different people, and I think it will be different in different oncology centres and radiotherapy departments. I think what would look good and what would be best is to have a link between prehab treatment, rehab, and late effects. I think if we're talking gold standard and an ideal world, that process would be flawless as it runs through. We would be better informing people about potential for late effects, and we would be better at predicting and identifying which patients we feel may struggle, and prospectively identifying them, bringing people into a late effects service much earlier, and being a lot more proactive about it, and having the support services in place that a radiotherapy late effects service needs. So having easy access to physio, dietetics, OTs, speech and language, people who are experienced in dealing with these kind of concerns, being able to refer for investigations, to send patients who've got rectal bleeding for a flexi-sigmoidoscopy without having to find lots of other people and jumping through hoops. So what we've got where I am and across the southwest is great, and I think in terms of what we've got going on across the country, we're really privileged to be working within such a good service, but I think there's a long way to go.
How long did it take you to set up your late effects service?
Yeah, I saw that question.
I thought so too.
It's an infinite amount of time. I'll tell you what my kind of story is. So, where are we now? 2025, 6 or 7 years ago, myself and my radiotherapy service manager began to kind of realise that this was an issue and a concern, and people were starting to talk about late effects, and we were starting to realise that actually we needed to be offering a service. It's in the radiotherapy service specifications. So we put a business case through our trust, which failed, and we couldn't get funding to set something up. So we approached our local charity called Focus, which is our oncology charity arm of our hospital charity, and they funded me a day a week for 2 years to start setting up some kind of late effects service. And for the second year, my manager funded me a second day a week, so I was working 2 days a week to try and scope out a service, identify what was available, start seeing patients, because we needed data and numbers to try and put another business case through. That business case didn't go anywhere either. So at that point, we approached Macmillan, and then we approached Macmillan with a bigger idea of a whole regional service across the whole of South West and the peninsula. And it took a little while for us to kind of get that up and running, but they've agreed to fund us for across the whole South West for 2 years with a 6-month extension now. So we're funded until March next year. So they funded therapy radiographer in Cheltenham, Bath and Bristol, and a navigator to work in Taunton alongside their established service. The Macmillan funding didn't get off the ground for the peninsula, so Exeter, Truro and Torbay have taken part in the project, and we've all worked together, but they've been allowed to have some radiographer time by their managers, and I know that has been incredibly difficult for them, because often their time isn't sort of earmarked if they're busy and that kind of thing. So it's been a big challenge, but that's where we are at the moment. So we've got a commissioning case into the commissioners at the moment to try and get continued funding for our service. But because we're always asked, how do you set a service up? How do you go about setting a late effects service up? What do you do?
With difficulty.
Sorry?
I said with difficulty.
With difficulty, and there isn't an easy answer, and it's different everywhere. And I think in some centres, radiotherapy managers are funding it out of their own pot. So they might be using what may have been money from a different post to allow somebody to do some work with late effects. I know that Oxford have got similar funding from Macmillan to set up a similar kind of service, but across the country, everyone's having the same problems because, you know, we know that there isn't a magic endless pot of money in the NHS, and we're all fighting for the same pot. So our prehab service is coming to the end of their Macmillan funding as well. So they're kind of bidding for the same pot that we're bidding for. And actually, I wouldn't want to make the decision really about where you spend those monies.
Yeah. I'm going to just have got one last question that I want to just finish off on. I wanted to ask Karen, what would be your sort of takeaway comment to radiotherapy professionals? Put you on the spot now, haven't I? Sorry.
Okay. You see, the radio, I'm trying to say the word now. I'm struggling with my speech. The people involved with obviously the radiotherapy are amazing. I couldn't fault them while I was going through the whole treatment. I think I would like for you all to be backing for our case for late effects. We need you all on board to help us progress. So help us fight our case for us, please. Because we need to move forward with this. Too many patients are suffering. And help signpost patients to support groups in the meantime, to support groups or where patients are actually getting a lot of knowledge that isn't being shared within the hospital departments. So maybe actually signpost all patients to relevant groups. Head and neck cancer straight to mouth cancer foundation so we can take them under our wing and help them as much as possible. And as I say, if you wish to join our group, please do. If you're on Facebook, I will let you in. We won't be putting you on the spot. We will ask. I do tag professionals for helping patients where I can't answer questions. But I would love that. So please do that. Thank you.
Thanks, Karen. Sarah.
Good. Thank you so much, Samantha, and also everybody who's come along this evening and asked questions and contributed to the chat as well. If you have learned something tonight, please do let us know in the comments. This is a really huge subject and we can't imagine we can tackle it in simply one webinar, but we really wanted to make a start, and it's also really emotive. So we are really pleased to be able to hold this. We will share this webinar online afterwards as well. So if you have any colleagues or networks or friends that you think would benefit from this, please do share and signpost to this. Thank you. And now I am just going to share some headline updates from the world of Radiotherapy UK. So first of all, I'd just like to start with a massive thank you. Thank you so much to everyone who has supported us this year. We are just 4 part-time members of staff, and without all the support we get, we wouldn't be able to fundraise, to create patient resources, to run our workforce programs, including our surveys, and such an impact in the media and in Parliament. And we really do appreciate everyone that helps us in the many, many ways that they do. We have recently launched the analysis and recommendations from our latest workforce survey. You can head to our website to take a look, and there's a link straight to them from the homepage. We're holding an event in Parliament next week, of which we have over 65 MPs have already RSVP'd. And everyone who attends that event will also get a copy of the survey so they can understand how important it is to support the radiotherapy workforce. Again, you can watch the ITV News report on our website. And we were so absolutely thrilled to see radiotherapy get the recognition it deserved last Friday with a feature special on ITV News. Rebecca Barry spotlighted our findings that 25% of radiotherapy machines in England alone will be older than the recommended age by the end of this year. And our chair, Professor Pat Price, is on the piece as well. And she is highlighting that it is not okay for patients when they should be able to access faster, better treatment, which can also help cut the waiting times. And one final invite, do take a look at the early stages of our Patient and Families Hub on our website. We're still testing, refining and adding content, but we have big plans for this part of our work. And you can go on now and start to get a feel for what we are trying to offer in terms of really trusted, accredited resources. And just before we say goodnight, a last reminder that our online festive fundraiser is on its way, and we have some fantastic prizes within the festive raffle. So please do consider buying a raffle ticket in support of our work. And thank you so much. Thank you so much again, Sam and Karen. It's been really enlightening and powerful and we really appreciate your time and sharing your experience with us. Thank you very much. Good evening.
Thank you.
Thank you very much.